Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today, I am joined by Elizabeth Holm, Rannaleet, and Dr. Matthew Burton. This is part 3 of an ongoing mini-series we're doing in collaboration with Telstra and Smile Digital Health on connected care. Dr. Matthew Burton, Elizabeth, how are you?
Fantastic. Good morning.
It's great to have you on the podcast, and I love doing these interviews where we cross international borders and get perspectives from around the world and feedback so far on the prior 2 episodes we've done in this mini series of episodes on connected care with Telstra and Smile Digital Health. The feedback has been great, and we're really building on concepts, and those full episodes are there in the feed for people to check out. Jump in the show notes of this episode if you wanted to jump back into those after this one. But today we're really kind of putting the lens on the population health data side of things and the role of infrastructure and how that applies into Australia, and potentially some lessons we can learn from other parts of the world too. To help us set the scene, firstly, I might get you both to introduce yourselves. Elizabeth, let's start with you. Tell us a little bit about you and what you do.
Thank you, Peter. So my background is I'm a pharmacist and epidemiologist by training, which means I love clinical things and I enjoy playing with data. And now I'm at Telstra Health, and my role here is the head of product for data and insights, which means I am responsible for thinking about all the exciting things we can do with the healthcare data in Australia. And I'm in a technology company, so we have the ability to get it done. I'm in the right job.
Yes, I was going to say you found your tribe. That's amazing. And what about you, Matthew?
Yeah, so Matt Burton, I'm a physician informatician and health systems engineer, and what that means, so I trained a little bit and actually worked as an industrial engineer, went to medical school, started a surgery residency, and saw a lot of not connected data in systems, and it reminded me of some things I'd seen doing manufacturing, where data was moved back and forth by human beings and caused a lot of issues with quality. And so I ended up training in medical informatics at a place called the Regenstrief Institute, and then worked at the hospital or health system they were affiliated with, Indiana University Health System, and then went to work at the Mayo Clinic, doing both health systems engineering and clinical informatics, and have done a lot of stuff around, it's tended into things particularly around getting best practices into practice, monitoring those best practices, learning from those best practices, and doing it in a way that makes it much more of a joy for the clinicians to actually practice instead of being told what to do. They're guided in what they do and are able to spend much more of their time interacting with the patient and actually directly addressing the patient's needs.
So good. Can't wait to tap into some of those insights throughout this conversation. As I mentioned at the top, we're going to dive into a little bit around population health data specifically. To help frame that up a little bit more, maybe I'll go to you, Elizabeth, and if you can help me out on firstly understanding when we say population health and population health data analytics, what are we talking about though?
Okay, that's probably a good place for us to start today. I think so. If we think about health, that can be my health or your health, Peter, or your health, Matthew. So it's like, how am I feeling today? Have I got any symptoms that I'm worried about? Do I have a chronic disease? It's individual level health. When we talk about population health, that's the health of a population. So it might be a state in Australia or the whole country. It could be an individual primary healthcare network. And instead of saying, what is the health of that primary healthcare network, what we're saying is how many people in that healthcare network have chronic heart disease, or what's the rate of conjunctivitis, for example. So you're asking questions about how many people have a condition at a point in time, or how many new diagnoses we're seeing is the kind of basic questions you'll be asking in population health. And then when you get to the data analytics of it, it's like, has the rate of that condition grown over time? So do we have more whooping cough today than we did 10 years ago? And we ask these questions to inform things like healthcare policy. How do you plan policy to make sure that we have better healthcare outcomes? And that's what the population health data analytics informs. It informs better policy, better healthcare.
That makes sense to me. Thank you. And if I was, particularly as an outsider of healthcare and informatics specifically, one could be forgiven to think that, it seems simple enough then, because we see the output of it like through the Australian Bureau of Statistics or Australian Institute of Health and Welfare. It says here's a percentage of people in this particular era. We talk about how in Western Sydney, burden of diabetes, and here's some stats, and got some really useful insights. That feels like, to me as an outsider, there's a very neat kind of system where if I at a patient level, I tick a box and then there's a little survey and here's a little graph that updates in real time. What's the reality of how that kind of data comes together, Elizabeth? And I'll find out from Matt too on how that's done in other parts of the world too. But I'd love to learn firstly in Australia, or at least your understanding of how we get from that patient interaction where we have that intention to then actually what it takes to pull it up to that aggregated view.
You're exactly right, Pete. Like, it would be lovely if we did have this chart that updated in real time and we could exactly see what was going on. We do have a few challenges in Australia, and it's partially based on just even where we've come from. Like, we have really fragmented data. And what I mean by that is we have information that we will have with our general practice, and it's maintained at the general practice. We might then, after we've been and seen a doctor, we might go to the pharmacy and get a script. The information on that is mostly maintained at the pharmacy. Some of it's shared with government, but it's mostly maintained at pharmacy as well. And they're going to have no idea of the other things that we might have done in terms of we also went to the supermarket and got a tub of ice cream on the way home. And these are all pieces of health information. So there's real issues in fragmentation. So it's not all put together in one spot. We have challenges and then in how we bring it together and how we bring it together in a timely way, because you mentioned real time, and we don't in most instances have real time. So it's the time taken to get the information from those separate places back into a joined position where we can combine it and use it to make an informed decision. And that time can be quite a lag, quite a delay. And I think even in Australia, we have questions about consent. So who's allowed to look at the information and when and for what purposes? It is changing. We've started sharing by consent, which is really exciting. So we'll be able to be sharing information between healthcare providers and also with government more freely. But it's changing. But it's all changing for the better.
Yeah. Sometimes I think, in Australia we're a bit behind, and we should just look to other parts of the world on how they do things, because they would be doing things a lot better. Matt, from your side, is the way we do things in terms of those challenges consistent with how you've seen in other parts of the world?
Well, you saw me smiling and laughing a little bit. So, and I mentioned, sitting in my surgery residency and moving information manually between systems. Right. And, I'd like to say that problem's been completely solved, but it's not. So even within a given hospital or health system, you still have systems that don't fully share their data. Right. And then you start to get across health systems, different kinds of providers, different kinds of information, as Elizabeth mentioned, you still have that problem. Right. And so it is getting better in large part through things like use of standards. There's also a lot that regulation can help with. And that's helped us. Where I trained happens to have one of the longest running, most successful health information exchanges that's facilitated sharing of that data. So the Indiana Health Information Exchange was built on sort of this database trying to help drive down cost for patient care. Originally was the use case, and then saw that they could leverage it for things like research and doing outcomes research and things like that. But it's the exception, not the rule. There's a few spots in the U.S. where we have that, but again, if somebody travels from one state to another state, or from one town to another town, that data doesn't follow them, right? And so you still find a lot of manual. We still get things. When I trained, it was often by fax. So fax me over the paper, and you still see that happening today. So I would say, likewise, it's improving, and we're seeing value that comes from that. More and more value in a number of different ways, learning those best practices, being able to deliver better care, not making mistakes and errors is another big one. But there's still plenty of room for improvement here in the US as well, for sure.
Okay. Yeah. Well, that makes me think too, because, even as you kind of alluded to it at the start, a lot of, and in that example, a lot of the benefit of having information together, it happens at a consumer level or a patient level. And one could think, well, if we're improving the outcomes for individuals at a consult level, and that should be our main focus, because then in theory it all aggregates up to better health outcomes at a global level. And I sometimes might think, well, should we spend a lot of time thinking about, well, we don't really have a real-time dashboard of the propensity of this particular chronic disease in this particular, and it would be interesting information to look at, but one might think, well, what's the use of having that? Because it seems like if we haven't done it yet, and we haven't nailed it, then should we really be leaning into, like, what's the burning platform, the why on what we would do with this information, other than look at it and go, well, that's really interesting. Elizabeth, on your side, what's the what are we missing? What impact does that have then of not having, this true real time or even close to real time representation of public health data? What are we actually doing? Because just because we can measure it, does it really mean that we should?
No. And I think you're right, Peter. I mean, what's the point of measuring something if you're not going to do something with that information? Yeah. Like it's the perfect question. And I think as well, you're right, there's definitely individual benefits to having that information available and shared and available in real time. And from the simple perspective of not having to tell your story multiple times. I had to do that myself a couple of months ago, taking a small child into hospital. Had to tell the nurse who I'd called first what had happened. And she said, just go to hospital. You go to hospital, you tell the triage nurse. Okay, you get seen by someone else, you tell the next nurse, then you see the doctor, you tell the same, and you're just telling the same story again and again and again. And as a parent, you're sitting there thinking, this is delaying my child getting the care that they need.
Right.
So at an individual level, there's clear benefits to having that information shared and available in real time. And I think if we think about it from a government perspective, and even just from what we as people expect the government to do, we expect them to be able to provide us with the healthcare services that we need in the time that we need them. And if they don't know that there is going to be a growing number of people with diabetes, for example, how can they do the workforce planning to make sure there are doctors who are trained to treat? And how can they make sure that they have funded medications that would the right medications to treat diabetes? And how can they help put in place other preventive healthcare measures? So they need to have that information in a timely way to inform the decisions they're making about policy.
Yeah. Now, spot on. And, I think back to, Matt, you were talking about, particularly in the US, examples of in certain health systems and HIEs, and a little bit more about the technology side of things. I'd love to learn a little bit more about what's actually required in terms of infrastructure and the technology side to enable some of those insights that Elizabeth was providing.
That's a great question. So, and it's that too is changing. So, some of the standards are changing. What's required of the standards. So, for instance, some of the standards may give you a means to share that data, but they are loose on, for instance, things like the codes that mean something, right? And so like the meaning of the data may not be shared with the data, right? And that sounds kind of crazy, but it gets back to some of the, and here we have a lot of misaligned incentives, right? And so if there's somebody who is, the system that's helping to generate the data or store the data, sees an opportunity to somehow monetize their understanding of the data, right? So they'll find loopholes in some of the policy where, I had an instance with a large patient advocacy organization for a major disease that's collecting data. And one of the major vendors was not willing to give up very important codes that they needed to try to track some of the care processes, some of the outcomes, and really made it, financially, nearly impossible, at least, to be able to. We'll give you the data. We just won't tell you what it means, right? And so you still have a lot of things like that going on. There are more and more regulations around what is shared, mechanisms for enforcing things like using standard terminologies and codes so that the meaning of that can be shared. There's certainly more opportunity to do that. Some interesting things. There's actually in the US more of an emphasis on, for instance, your health insurance, your payer sharing information with other payers and sharing information with the providers and the patients than there is with the providers sharing information with each other, right? And so you think about that from a patient perspective, it's like, what the insurance company has is, like very high level, right, information. They don't have the details. How's the doctor supposed to do anything with that, right? It's not that there's no benefit. It's just not to the level of benefit. But again, some of those things are starting to change. Some of the other things that we're seeing, so like the raw data may be shared, but things around how did I come to the decision to do this, right? What decision did I come to? Things that we would consider like sort of in the plan space for what we are intending to do for a patient. The patient leaves, that's stuck in, at best, maybe a narrative note, right? So we don't, for instance, things like orders often don't get shared. So, they go from one provider or one hospital to another. A lot of times that kind of information doesn't get shared over. So, if I'm transferred between hospitals, the new hospital has to completely start from scratch.
Yeah. That's a really interesting point about the alignment of incentives and from my own experience anyway, be it in Australia or other parts of the world, I think healthcare systems can be good at sharing information if there's a direct alignment with getting paid. To be fair, like the financial information that gets sent around to payers and providers and that's all there. But as you say, Matt, a lot of information that may come through is not going to be useful to a clinician or to a patient because it's more just about who's going to pay the bill. I think then in Australia, Elizabeth, about if we were to create a repository, like starting tomorrow, here's this repository of information that gives us a view of population health information. You talked about before about one of the major benefits of this kind of information is not just like at this point in time, but over a period of time. Is this something that's quite a long-term strategic thing we need to kind of work on now? Because if we were to start tomorrow, we're not going to get a 5-year historical view of like what happened, pre-COVID, or maybe I'm wrong. Like, what does that building, like, where are we at with this whole process? And is this something we got to start building now that's going to be useful in 10, 20 years time? Or are there going to be more immediate benefits in doing this kind of thing?
Yeah, I think there's already some work underway. Even for example, AIHW are looking to work out if we can do a national repository of primary healthcare information. There's work being done on patient level individual data assets. So how do we have that patient level information? And I think those are just a couple of examples, but it's really showing that we're doing things. We're sort of chipping away at the little elements that have made it harder historically. And we're demonstrating the benefits of doing that work. So I think there is definitely a lot of work to be done now, and we're starting to do it. We will start, and I think the way that it's being done in terms of, so we can do it by focusing on an individual disease first or a specific population first. So identifying, like to your point, Peter, it's like, what's the problem we're actually trying to solve? What are we going to do with the information once we've got it? And then working backwards. Okay, so what's the information we need to get? What's the detail that we need here? Where do we get it from? And solving it that way, I think it makes it quite tangible.
Yeah.
And it means we can, and it makes it also achievable.
Yeah, that's right. I think taking it in parts, and there's a bit of strategic thinking there, but there's some real benefits to act now on this. And I'm thinking back on one of your points, Matt, around the role that standards play and having some consistency in terms of that data. I can think objectively about, well, it'd be great if all the data spoke the same language or was consistently coded and things like that. But the real benefit, because I know there's probably more progress in the US compared to other parts of the world in terms of standardization of health information. What role does, we talk about HL7, we talk about FHIR, we talk about the standards of health data. What's that current state of play, and beyond just having tidy data that makes it easy for it to connect, like what's the benefits of that?
Yeah, so when you mentioned HL7, and I don't know how much earlier versions of HL7 are used in Australia, but in the US, things like version 2 of HL7 has been around since the late 80s and early 90s, right? And so it's been incredibly useful to have that, and that Indiana Health Information Exchange that I mentioned leveraged that considerably, right? There are also some limitations and some challenges, and especially getting to, using more modern technology to that, but even more so, some of the things that FHIR has enabled are, we've talked about, Elizabeth mentioned earlier, insights, right? And so there's the sharing of the raw data, right? But there's a lot that the clinicians tend to do, often in their heads. Sometimes in the EHR will do things, and you can think of something as simple as calculating a BMI, right? Or an EGFR, which is a measure of how your kidneys are functioning, right? And so it applies just a little bit of math to it, or some other computation to it. Sometimes that information gets shared, but often, the more that's done to help that individual patient, locally, that's done in the local systems, and there's not been a great way to share that, right? And so one of the things that we're seeing is we can actually do things like look at disease severity, disease progression, risk scores, those sort of things. So we have, a deeper, more holistic understanding of that state of health, right, for an individual patient, but that can then be used to aggregate for some of the things that Elizabeth was talking about. So understanding things like policy and where certain services are needed, but also for things like clinical outcomes and health services research, understanding like what is actually an effective cancer screening regimen, for instance, right? A cost-effective cancer screening regimen and those sorts of things. But if you don't have an understanding of, some of the patient-specific factors that can be rolled up at a population level, but also what did they progress to, and how aggressive was that cancer, and start having more and more information that gets into more of a comprehensive description of the patient's health, either for individual diseases or more broadly talking about health. So one of the things that FHIR and really some of the components within FHIR, so the clinical reasoning module in FHIR, things like CQL, which is a clinical logic language, have enabled are better means of defining those sorts of things, applying them in a consistent way, and then sharing those insights as well as the raw data across individual systems for direct patient care, but also in aggregate then for doing things like better population health and clinical outcomes kinds of studies.
Yeah, so that and this is often the direction this conversation goes, right? Like the technology is there. It's not so much a technology problem per se. There's a lot to solve there, but you know, I playing this out in my head, Elizabeth, and as you kind of touched on earlier too, you know, share by default in Australia is kind of starting to get some traction in certain parts of healthcare, and you know, been legislated in, and there's good reason for that. And I guess in our little bubbles of health informatics or digital health or in the healthcare system overall, we can see all the public good that comes from this. But it doesn't matter what part of the world you're in. I just feel like in this current climate, if the messaging wasn't right, at a general public level, if there's a high chance that kind of message of, hey, we're going to aggregate your healthcare information and trust us, we're the government type thing. Right now, I don't feel like that may land the way that everyone would want it if that message isn't communicated appropriately. So how do we, with all best intentions and probably all the right rigor and things to be able to implement it, in the end, if the public understanding of what's going on here is misaligned with what the intentions are, it doesn't matter what the intentions are, it's just not going to get out of the gate. So how do we ensure that public trust and all the data governance and things like this, that to not just do it, but then I guess have that broader, because this is information that affects, this is information from everyone across the world. So it impacts everyone. It's not an easy question, but this is stuff I think about a bit. Elizabeth, help me out.
No, I think about it too. And I think there's so many factors here. And I think you're right. Historically, we've been quite cautious as individuals about sharing information, and especially our health information, because it can be quite private and it is personal, and you don't necessarily want to broadcast it. So I think this initial hesitation and caution is completely warranted. You're right, like the security that we have within the technology systems now, the access controls, all of that helps, but there's an element to messaging and being clear about what those security features mean. And there's an element to say and to demonstrating as well what the benefit is. But I also think that we as a group of people, we've moved on a bit as well in terms of how we feel about sharing data. We see it in lots of other areas. So in Facebook and LinkedIn and Twitter, people are sharing all sorts of information that you might have historically been quite surprised to see. And I think there's even a bit more expectation in some ways, or we can find a light where companies might be tracking us a little bit. And it just, like, a simple example is, I have an app that I use to book restaurants on, and it recommends new restaurants for me based on the types of food I like to eat and what my budget is. And that's basically using my information to work out what else I might like to do. It's the same concept, and I'm happy about it. And so I think we as a population are getting more comfortable and excited to have that information shared. It still does need to be really safe and secure, but I think we're getting more excited about the potential benefits that can achieve as well.
Sure.
Matt, what do you think?
Yeah,
that's it's interesting. So I have this conversation a lot with family and friends around, so if you look at what social media does, right? Like, they create what they call phenotypes, right? So they do psychological phenotyping of us. Okay. So whether you like it or not, and I guess it doesn't really matter whether you like it because you're doing it, right? You're providing information for somebody to better understand how you think, how you feel, how you make personal decisions, right? And you think about it, it's like, man, I'd much rather somebody know about my diabetes. That's not nearly as big a secret as, a lot of the things that I think, my political views, my religious views, right? Those sorts of things. And, yet we share that pretty readily. I think on the other side, to Elizabeth's point, is, and, again, a lot of conversations with family. It's like, well, how do you not just know this? I was just over at this, clinic or hospital, next door, right? And it's like, well, the doctor's office is a separate business entity and they use their own EHR, and it may not be connected to the hospital, right? And so they don't really understand it. So I think there's becoming this expectation. I think also showing the benefit, right? And I think that benefit you have to show at the individual level, right, as well as in aggregate in the population level, right? So things at the population level, it can do things like drive down cost, improve outcomes, right? Some of the just like the basic fundamental things that we want from our healthcare, right? It can free up the clinician's time so that they can actually hear me when I'm explaining, the nuance to why I may not want to take a medication in this drug class, right? Because, my uncle, it ended up exacerbating his depression and he committed suicide, and I don't want that to happen, right? Things like that, the clinicians need to have time and attention spent on interacting with their patients, and they can't do that if they're trying to chase data around and try to recreate this picture in their head. So I think there's the individual level, there's the aggregate level. I think there's also sort of this understanding of, what's being done with that information, who's doing it. So there is a trust component as well. And that's the examples that I've seen work well. I mentioned the Indiana Health Information Exchange. I mean, it's literally a trusted third party, right, that is managing that data. It's not one hospital system just took everybody else's data. It's not even one governmental entity. They all have access, and they have, to your point earlier, Elizabeth, they all have, here's what this group can use it for, right? Any of them can use it for direct patient care, right? I may be able to use the data in aggregate against my own data to make even some business decisions about where do I open, urgent care or a new clinic or whatever to provide better services and serve a certain area. Or, if I'm a researcher or in a governmental role, right? Okay, I can only look at it in aggregate, right, to inform, decisions on, what do we need to incentivize, or what should we reimburse for, or those sorts of things, or, what kinds of practice patterns seem to work better for these subsets of patients.
Yeah, and not to labor on it, but it makes me think a lot too, because there's loads of buckets of examples that, as Elizabeth pointed out too, with recommendations on things, but also, like no one really complains about the data, like the information that comes from your phone to go to Google Maps so that they know how many phones are in a particular spot, because then that tells us that there's a traffic jam there. Because the benefit to me is that, well, I might avoid that, and then I'll save being stuck in a traffic jam. But if I was to get to work and then I get a phone call from a dispute lawyer, like to know that I was hey, I know you drove past this particular place, and did you find it interesting? I'd be like, what's with that? And we also know like other examples of social media platforms from different parts of the world, and people didn't really care about like if whatever they do with my information, I'm going to be entertained and I will put it in, and that's what it is. And whether that's the right decision or not, people will choose to do things because there's a benefit to them. So in a healthcare setting, the amount of opportunities we have to be able to to that point around research, and the amount of people with caring for people or themselves having ongoing multi-morbidities or chronic illnesses that are challenging, or if it's going to help them address issues, or even then understanding in a community, like if that can be translated into, well, we know that X% of the people have this, so that's why we're doing this. I feel like those types of good maths. But if it turned into, well, someone very high up is getting rich because they're mining my information for X, Y, and Z, or because they're observing what I do, then, which I think historically, for whatever reason, right or wrong, that's kind of been the messaging that's happened when we usually see things fall down. So I feel like there's a lot of work that once all this work is not, it's never done, but once we get to a point to be able to do this at scale, that the real work begins in bringing people along. And I guess we can bring people on that journey now with and having options for consent and open communication at a clinical level. That's why these things are super important, because then we can unlock that power. I'm going to pause my rant there, otherwise I'm going to take over the rest of this episode. But it's one that we get stuck on a lot. So, if I was to start to round out this conversation, I think about we've touched on the what we need in terms of population health and some of the technology that might be required to do that and the benefits of that. If you were to sum it up to both of you, we'll start with Elizabeth. Like, what excites you about this I guess the stage that we're at right now, all the kind of pieces moving together and the current state of play. Or what happens when we get this right? Like, what does that future look like?
It's a bit strange. I almost feel like, I don't know if you remember, there was this TV show called The Jetsons.
Sure.
And they had video phones in it. And as a kid watching that in the cartoon, you're like, wouldn't that be amazing? Yeah. And we're there now. We have that. And that's kind of how I feel about where we are with technology and healthcare data. There are all these things that I've been talking about for 20 years. It's like, imagine if we could share this. Why are we still faxing? I'd love to understand like what this patient history was, like what their lifetime journey was, how they got here. We're actually there now. We can really start to do some of this like longitudinal analysis of understanding what happens to a patient over their lifetime. We can understand what policy is more effective. Matt has some great examples about how we can change from like a more really high level clinical guideline to a personalized guideline of how to best manage someone's condition that potentially could even take into account preferences about treatment types or lifestyle choices. So we are there now, and we have the sort of that computational power to do it. It isn't nearly as expensive as it used to be. So for me, it's just about we can get it done, and we are going to take this forward, and the benefits to individuals, the benefits to the healthcare system, the benefits to health outcomes. It's huge. I just can't wait to see it happen. I'm so excited.
Likewise. Nice one, Elizabeth. What about you, Matt?
Yeah, I think this is a great question. I keep coming back to some of the work that we did at the Mayo Clinic. It was really interesting where, and we ended up presenting the information on a mobile platform, right? And so one of the things that you noticed was the clinicians weren't going back to a desk, right? They were able to just use the mobile platform, right? And they were spending more time on the wards in the clinic, face to face with the clinicians. Right. So I almost think of and at the individual level and at the, at the practice level, a future of where, it's you don't, the patient or provider don't even really think about the information systems, right? They don't even think about whether it's there or not there. They get to the point where they take it for granted. Right. And they're not spending their time, here we get stories of, and I've had this happen where actually just had this happen yesterday with my daughter, and took her to a pediatric hospital and the clinicians like literally sitting here looking stuff up, typing away, and I'd say more than 50% of the time was spent looking for information in the computer and it wasn't even entirely accurate. My wife, who's also in healthcare, sitting there having to correct and adjust things that they weren't quite able to just find the right detail on. Right. So that goes away. Number one. Number two, then, the clinicians are making decisions and with the patients, right? So things like shared decision making, which by the way, you actually need population health information to do that, because I need to understand like where I fit in a population and what's more likely or not to benefit me and in what way. Right. So it's another thing that I get from that population health data. But, actually being able to use it as tools to interact with the patient, thinking and working in the way that we either were trained or got into healthcare thinking that we were going to be able to practice, right? And a lot of it may be getting back to, in some ways, doing things the way they were done before we had electronic health records, right? Where, I can just be jotting something down on a piece of paper and not even thinking twice about it, right? But having all the benefit of that information. And then I think the other thing, too, is as we enable this, you really get to it's an interoperable, but also rapid cycle learning health system, right? Where it's not, you don't have to perform, these really expensive, long-lasting clinical trials on everything. You get to essentially what they call these real-world clinical trials, right? Where we're starting to learn more and more and more from the data on what works, what doesn't work, what works for different subgroups of patients. So that we're actually able to get better and better at care without having to, do these really big, expensive, time-consuming kinds of studies.
I like the look of that future, Matt. So I appreciate you breaking that down. And look, that's probably all the time we've got time for this conversation. But I feel like it's been a great addition to this ongoing mini-series that the Talking HealthTech has done in collaboration with Smile Digital Health and, of course, Telstra Health. You can jump onto the Telstra Health listing on our website to see all of those episodes there, and it'll be linked up in the show notes of this particular episode, and look forward to doing it again very soon on the feed. So, Matt, Elizabeth, I really appreciate you making the time.
Thank you.
Thank you, Peter. Thank you, Matt.
Yeah, thanks, Elizabeth.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.